trigger points. So remember that you're going to look for this AC ligament. If in fact it's very inflamed, you can use an NSAID. The one I find works the best is ibuprofen, given in dosages of 800 milligrams 3 times a day for approximately a week. If it's a minor type of inflammation, this will often take care of it, assuming the patient can tolerate that. If they can't, there's a new medication on the market which uses Voltaren, which is an NSAID that is dissolved in DMSO, which will carry the Voltaren right across the skin into the area of pathology with using a very small dosage. Or you can inject the area with a depot preparation of the steroid. And you have to remember that the steroid doesn't start to work for 2 to 3 days. So tell the patient that the local anesthetic will wear off, their pain will come back to some degree. It may not be as bad as it was before, or it could be worse. Use an ice cube on it to minimize it if it flares up, and then in 2 to 3 days it will start to get better. Now again, here are the muscles you have to work on. The upper trapezius, which again can be giving you all these referral patterns, and remember the patient may report these things, and the patient's not crazy, they're just reporting what they feel. And you have to accept that and tease out the various muscles that are involved by not only listening to the patient, but palpating these trigger points. It's really important to develop that skill. And again, there's a referral pattern here to the rhomboid area and out to the, especially if somebody has a problem with the AC ligament, this could be the cause of the tenderness. So you have to look for this area, treat with the laser, and then palpate again to see what's going on. Rhomboids, again, are right along the interscapular area here, just along the border of the scapula, and you're looking at both the upper and the lower portions of the rhomboids. Levator scapula actually refers pain up to the neck as well as down into the shoulder. So again, shoulder pathology may show up as a patient saying their neck is stiff. That is the common report that the patient will tell you. They feel like their neck is stiff rather than they can't turn. The infraspinatus, again, is quite important. Occasionally you'll see referral up into the neck. The most common areas are interscapular and down the arm to the dorsal surface of the forearm and into the shoulder. Remember, this one, the upper lateral one, will be the one that goes deep into the shoulder, where a patient will tell you they don't feel tenderness in the shoulder, but the pain is deep inside there. You can see here the formation of the rotator cuff with the infraspinatus and the supraspinatus coming down from up in here. Supraspinatus trigger points are here, and you can see the tendon coming down to form the rotator cuff, and you'll see trigger points in that and give you significant tenderness over the shoulder and perhaps even down into the elbow area. The latissimus dorsi, again, will affect the shoulder function and may give you referred pain down here. And clearly, because of its insertion on the humerus, is going to, if it's tight, it's going to limit the ability of the shoulder to function normally. The teres major will give you pain in this area of the shoulder. You can see the trigger points here. and you may inactivate this trigger point by going under into the axilla. The teres minor is shown just giving you this, but in fact will also give you a significant dysesthetic type of feeling on the dorsal surface of the hand. And I think this is the last one, showing again the deltoid. But you can see how you have to go to every single muscle that affects the shoulder and helps to operate the shoulder, because any one of them may be dysfunctional due to trigger points, and in order to get the best response you need to inactivate every one of them. And here's the coracobrachialis, which again is often hidden by the deltoid, that again needs to be addressed. Pectoralis major and minor, we've gone over this before from the previous case. And now we're into the question and answer time. Do any of you have any specific questions regarding any of these three cases, or any specific cases that you may have run into on your own? Just enter the questions into the chat box. Okay, what we're going to try to do is answer some of these concerns. Again, we've been asked, how much do you really have to do in terms of examining all these different trigger points? And the answer is, that's one of the things that takes the time when you're dealing with these kinds of patients. You have to look at every trigger point in every muscle that could possibly be responsible for the problem. Because if you leave any of them behind, the entire problem is going to come back sooner and perhaps in a flared-up situation. And the patient will not be happy the next day or a day or two later when it appears as though what you've done hasn't really helped. So the advantage of the laser is that you can do all these trigger points without the patient saying, I've had enough, stop the injections, they hurt too much. It's a major advance in terms of being able to do a full and complete treatment of any functional unit, whether it's a shoulder, a neck, a hip, a knee, or an ankle. Did that bring up any other questions? Sometimes just one question from one of the participants raises questions among others. One of the questions that was asked earlier today seems to be of great concern almost with every one of these webinars, and that is, do the insurance companies reimburse for your time? Because obviously the time is significant. At the present time in my area, and it may vary depending on what area you're in, unfortunately it does, Aetna, Cigna, United Healthcare all reimburse for use of the low power laser. Aetna appears to be the best and seems to be reimbursing based on the fact that I as a physician am doing the treatment rather than considering me a physical therapist. Cigna and United Healthcare and the Blue Plan in our area all seem to be only willing to treat this as a physical therapy modality and are reimbursing based upon essentially one unit of this treatment. And clearly if you're doing 3 or 4 units, and each unit in my billing system is every 15 minutes. And you have